Thank you everyone for joining us today on our webinar Preventing HPV in 2025. I know we have a handful still jumping on, but we are going to get started. Happy to see so many are able to make it today. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for Healthy North Dakota. It is a nonprofit organization established in 2022 with a mission to promote health and wellness across North Dakota by working at the community level. We continue to expand our statewide coalition to foster collaboration among local communities on common initiatives. By becoming a member of the coalition, you will be the first to receive information about educational webinars such as this, updates on relevant public health information, legislative news, as well as access to digital advocacy resources and toolkits. Some housekeeping things to cover. Webinar attendees will be automatically muted for the presentation. If you do have questions, please put them in the chat box and we will be monitoring those questions as they come in. We will record this presentation and reserve time in the end to answer any questions. After the presentation, a link to the recording will be sent out along with an evaluation survey. It is my pleasure to introduce our presenter today, Dr. Sharon Humiston, who I had the pleasure to meet at the last North Dakota Immunization Conference. She is the Director of Research for immunize.org and Associate Editor of the newsletter IZ Express. Beyond her clinical work, Dr. Humiston's career has centered on immunization delivery in three ways: education, research, and quality improvement. She worked on HPV vaccination initiatives for both the Academic Pediatric Association and the American Academy of Pediatrics. She served on the steering committee of the American Cancer Society's National HPV Vaccination Roundtable and started the Roundtable's Provider Training Task Group. Dr. Humiston previously worked in the training and education branch of the CDC's National Immunization Program, now called the National Center for Immunization and Respiratory Diseases. Her work is detailed in her 147 peer-reviewed publications. Thank you for being here with us today, and I will turn it over to you.
My pleasure for being here. Thank you. Okay, and I am going to see if I can get this to work. Are you seeing my slides?
I am.
Great. Okay. So I'm going to be talking about prevention in 2025. There are a couple of updates. A lot of what I'm talking about, you probably have already heard if you're familiar with HPV at all, but I just want to bring up that how exciting the data is about how well the vaccine is working, continued good safety and duration of effectiveness, and some updates about what ACIP is going to be thinking about next in terms of the schedule for this vaccine. I have no financial disclosures related to HPV vaccine, and several of my slides, I stole them from CDC experts who make presentations at the ACIP. I'll mention the ACIP a few times. That's the Advisory Committee on Immunization Practice. And I've stolen some of their slides and also from my research partners, Drs. Peter Szilagyi and Cindy Rand. So our learning objectives for today: why vaccinate against HPV? When someone asks that question, I want the answer to just trip off your tongue because the answer is pretty exciting. HPV vaccination rates in the United States and in North Dakota in particular, starting at age 9-10 rather than waiting till 11-12. And the big question at ACIP: will the US change to a 1-dose schedule instead of the typical 2-dose schedule that we use now? And then I'm really going to spend some time on resources. I think a lot of times we attend a webinar and we get what we get out of it and we remember what we can remember. But I want to actually give you a fishing pole about where to turn for information as it evolves tomorrow. So to start with, this is the number of HPV associated and HPV attributable cancer cases per year in the United States, an average from 2014 to 2018. And I just, just to remind you that there are several sites where it's usually squamous cell carcinomas. They can occur at the oral pharynx, the anus and rectum, and the genitals, both female genitals and male genitals. So in this slide, you see, I hope, is my pointer working, Mary? Can you see my pointer?
Yes, I can.
Okay. So if you look at the cervix, there are 11,000 cases that are, this is the estimated number of probable cases caused by any HPV type. And so you see for females, it's about 11,000 cases of cervical cancer per year in the United States. Worldwide, it's much higher, but and this is just United States. The numbers are lower for the other genital sites. Now look at the oropharynx. For males, it's about 12,000. So one of the things I want you to notice is that in these years, the rates were higher for males in the oropharynx than for females in the cervix. So one of the things that comes up a lot still is that people say, why does my son need this vaccine? He doesn't have a cervix, because there's still a belief that this is a cervical cancer problem only. And that's not true. Overall, females have more HPV cancers than males. But if you're looking at both sexes together, about more than 36,000 cancers per year in the United States. So we need, the reason one is we still have HPV cancers, and we would like to be in a place where we get rid of HPV cancers. Now, some of those cancers are going to take a really long time, and I'll show you why I say that. I'm going to first focus on cervical cancer and precancer. This is, I know many of you are eating lunch or just ate lunch and may find this disturbing. We know that cancers usually start out as a localized area of disturbance in the cell replication and goes and spread further and further. So we want to catch this as early as possible before the cancer cells spread beyond, the early boundaries. I show here the 5-year relative survival rate for cervical cancer. It depends on the stage that a person gets at diagnosis. So for localized cancers, it's 91% 5-year survival. So that's much better than if it's distant and your survival rate is only 19%. But even at if you catch it when it's a localized cancer, it's still not 100% survival. To me, that's really important. We want, it would be so much better to prevent the infection than having to even have a 9% chance of not having a 5-year survival. Another thing that I didn't know when we first started talking about HPV was, I figured, if we catch it as a precancer, what's the big deal? Why would that be important to me? But the reason is that even precancerous lesions have implications for a woman and her offspring. There are hundreds of thousands of high-grade cervical cancer lesions found each year. So the numbers get really big when we're talking about precancers. And the removal of these, usually they cut out a cone-shaped area from the cervix in order to catch all the precancerous cells. And or they either use a scalpel, as shown here, or a loop electrosurgical excision procedure. So it's done with an electrosurgical. But in either case, again, you hear about a cold knife cone biopsy. That doesn't sound like a good day. But in addition to it being painful and scary, the other thing is that it makes it so that the removal of that piece of the cervix makes it so that a woman is more likely to have a miscarriage or preterm labor. So that wedge of cervix is super important. You know, you've heard the expression an incompetent cervix, and that just means that it can't hold the pregnancy to term, which turns into a pediatric problem then. This slide shows you the US HPV-associated cancer rates among females by cancer type and age at diagnosis. This is 2017 to 2001. And what you see here in this blue line is the cervical cancer. The purple is anal cancer, red is oropharyngeal cancer, green is vulvar cancer. So you see like vulvar cancer goes up and up with age. This is 20 to 29 years of age, 30 to 39. So this is like the natural progression. So for most cancers, you start seeing them in the early 40s, and they might peak like the anal cancer peaks at about 60 to 69. Same with oropharyngeal cancer. For cervical cancer, it starts much earlier and peaks much earlier, so that by 40 to 49, you've got a peak, and it is overall more common. And one of the things I want to point out about this is that these are childbearing years. And so if you have a cervical cancer during those years, again, implications for being able to bring a child into the world. And so again, one of the things that drives me crazy, you hear people say, well, they don't want HPV vaccine because they've heard it interferes with fertility. Quite the opposite, that HPV vaccine helps protect your fertility by helping to protect your cervix from cancer and precancers. Another thing I didn't know when I first started learning about HPV was I didn't know what they meant by oropharyngeal. So I'm going to assume that some of you might not know. The areas in the slide that are in purple are what counts as the oral pharynx. So these are the tonsils and the base of the tongue if you're looking sideways this way. And if you're looking straight on, the tonsils, the base of the tongue, all back, way back far. So again, one of the things I want to point out is that dentists do look for HPV cancers when they're doing exams. I always think it's so disgusting, but that dentist gets gauze and pulls your tongue forward to be able to look way back there. Like if I'm just doing an exam for strep, I'm not going to see the base of your tongue or your tonsils probably. And so the dentists are becoming really good allies in the fight against HPV cancer, because one of the things that they're doing is saying, as they're doing the exam, oh, what I'm doing right now is looking for signs of oral cancer. And one way you can prevent that is by getting an HPV vaccine. So we're doing a project with dentists in Alabama to get everybody on board, and even to have them give out a prescription so that the family will take the prescription from the dentist to the pharmacy or back to their primary care to say, hey, I really want this vaccine. Okay. Here are the rates. Now, before I showed you in females, now I'm showing you in males, the rates of HPV-associated cancers by type. And the vast majority of them are this orange oropharyngeal. But see how much later in life it peaks in the 60s for males. So one of the things I want to point out to you is you're not going to see a lot of data about decreases yet in oropharyngeal cancer, because it takes so much longer for that to develop than to develop cervical cancers and precancers. So in case that you were wondering, why am I not showing you changes in oropharyngeal cancer, it's because it takes so long for it to develop. Well, here's another thing that I think is very exciting. We started in the United States with an HPV vaccine back in 2006, and you see the recommendation as they changed over the years. So we are coming up on, in 2025, we're at 19 years now of using this vaccine in the United States. Some other countries started before us, but we already have almost 2 decades of experience under our belt in the United States. So under our belt, so to speak. And so I love knowing that it's almost 2 decades, because now this isn't a new vaccine. All of those worries about we don't have enough experience, we have plenty of experience. More than 100 million people vaccinated in the United States alone. So very exciting. And the other thing I want to celebrate is the effectiveness of the vaccine. So what you're seeing here is the prevalence of vaccine type HPV, the 6, 11, 16, and 18 in females. This is data from 2015 to 2018. And you see over different years. So the dark blue is the pre-vaccine era. The lighter blue is 2007 to 2010, 2011 to 2014, and this is from 2015 to 2018. So not even the most recent slice, but pretty good. Okay, and what you're seeing now, you would expect that younger people, younger females are more likely to have been vaccinated, because we weren't vaccinating people who, we only have 19 years of experience with the vaccine. So people back who were 25 to 29 would not be likely to have been vaccinated. So we see that for the 14 to 19-year-olds, there's been an 88% decrease in HPV infection. So part one is just how common is the infection. Then we look at the 20 to 24, and again, 81% lower. So this vaccine we know is really stopping infection. And so the next obvious question is, well, is that affecting precancer rates? So that's my next slide. What you're seeing here is the cervical precancer incidence among screened women, 2008 to 2015. This is an HPV impact project. So this graph shows you the estimated cervical precancer incidence rates per 100,000 screened women. And in the light pink is the age group 18 to 20. And you see that from 2008 to 2015, there has been a persistent drop. Similarly, with women 21 to 24 years of age, a really nice drop. Now, in that older age category, where they are less likely or unlikely to have been vaccinated, the rate actually went up. That's probably because we're doing different screening, that the intervals have decreased and we have more sensitive screening and diagnostic tests than we had back in 2008. And so that's probably why this number is going up. So infection down, cervical precancers down. What about the rate of invasive cancers? I'm going to show you this data from Sweden first. Among my many lack of knowledge is lack of knowledge of geography. So I put in, where is Sweden? It's all the way up here. Who knew how high it was? This is Norway and Finland on either side of Sweden. Okay, so Sweden has a registry where they know if you have cervical cancer, because their healthcare is all on registries. So the government pays for everything, and so it's like having an electronic health record for the entire nation. And so they have a registry that has 1.6 million females in it, aged 10 to 20. and looking at data, we're looking at data from 2006 to 2017. Over that time frame, the incidence dropped to 47 among vaccinated women and 94 among unvaccinated women. So you see that the unvaccinated women have almost twice the rate of cervical cancer as vaccinated women. Looks like the vaccine is doing a great job at preventing cervical cancers, which, kind of, it's great if you're stopping infection, but this is really where the rubber meets, and stopping pre-cancers. But like, this is really, really exciting. The incident rate ratio when controlled for confounders is 0.2 if vaccinated before age 17 and 0.47 if vaccinated at 17 to 30. So that says two things. One is the vaccine works much better if you vaccinate before age 17, which is to be expected because we want to vaccinate before there's any possibility of being infected with HPV. But the other thing it says to me, so if if it were 1.0, that means that there's no difference if you're vaccinated or unvaccinated. So even the women that were vaccinated at 17 to 30 have an incident rate ratio of 0.47, so much lower than if they hadn't been vaccinated at all. And that's, to me, surprising. Again, I thought that if we didn't catch them right, before they turned 15, that the vaccine wouldn't have any effect at all. But even women vaccinated 17 to 30, there is still an effect and a good effect. So to me, this makes it, the whole thing about in the United States, the recommendation is to keep vaccinating through age 26. And I was never very excited about that. But seeing this data makes me much more excited about if someone slips through and gets into being a young adult unvaccinated, it's still worth vaccinating. All right, this is a graph that just shows you what I just said. The orange line, this is the HPV vaccination status. The orange line is vaccinated. This is the age at follow-up. So you're getting older, older, older as you go to the right. This is the cumulative incidence of cervical cancer per 100,000. You see, if you are unvaccinated, the orange line just goes up and up and up, which goes along with the natural history of the disease. We said that from 20 on, the incidence of cervical cancer goes up. So that's just the natural course of the disease, unfortunately. This in the blue line shows you women vaccinated at 17 to 30. So the rate of cervical cancer isn't zero, but looks like it's about half of what it is. We said 0.47. So about half of what it is for unvaccinated. But then the really exciting, and this is where, why I'm glad I had my daughter vaccinated, is if you're vaccinated before you're 17, you're in the green line, almost no cervical cancer at all. Very exciting. Okay. This is a more recent paper. This is for the effects of HPV cancer on the development of HPV-related cancers in any site. It's a retrospective analysis of a United States-based cohort published in the American Society of Clinical Oncology. And what they found, and the reference is here, what they found was that males vaccinated for HPV were at decreased odds for HPV-related cancers. So that's good news, especially head and neck cancers. Now that we looked at the natural progression and we said not a lot of head and neck cancers until later in life, but we are already seeing an effect. And for females, and this is the reason why I bring this up is because before we were looking at data from Sweden, well, maybe there's something inherently different about Swedish women than the women in the United States. And so this data is from the United States, and it shows that females vaccinated for HPV had decreased odds of cervical cancers and HPV related cancers overall. So down for infection, down for precancer cervical infections, down for cervical cancer, and down for head and neck cancers already in just 19 years. This shows you the trends in cervical cancer mortality. How many people died from cervical cancer among US women younger than 25? You know, you'd figure that not a lot of women die from cervical cancer before 25. This is 1992 to 2021. And so here is when we started vaccinating. And you see that the rate of mortality from cervical cancer was going down before we started vaccinating. The orange line is the projected line. And that's because medicine marches on. We're doing a better job of diagnosing early. They have the new HPV test. So we do better screening, and the OBGYNs are always working on better techniques of removing the cancers early. And in the United States, through public health, we have worked hard to try to get more women in to get screened early. So we're seeing improvements even before the HPV vaccine. So here's when we started vaccinating. Now this was projected was that it was just going to gradually go down. But what has actually happened, the dotted line is the observed, is that it has plummeted. So less cervical cancers and less death from cervical cancer. Wonderful, wonderful news. So this, I think that this is very exciting. In the United States today, how many people are living with oral and pharyngeal cancers? About 430,000. Cervical cancers, almost 300,000. Anal cancers, 81,000. And the other genital sites, about 100,000. So our work is not done because we want to prevent cancers before they happen. That's another thing I just have to point out is the HPV vaccine is not a therapeutic vaccine. You know, it's not going to reverse the cell damage. Okay. What is the lifetime risk of developing HPV cancers in the United States? If you look at these numbers and look at the number of people in the United States, the lifetime risk of developing cancer, if you're unvaccinated, 1.2% for oral pharyngeal cancers. Now, not all of those are HPV related, remember, but 1 out of 100, you know, I don't want my husband to go through that. Cervical cancer, about 6 per 1,000, anal cancer, 2 per 1,000, and the other genital cancers, about 3 per 1,000. So the risk is not trivial. How many, given these numbers, how many adolescents do you need to vaccinate to prevent one HPV cancer? Because the lifetime risk overall, if you add these up, is 2.3%. HPV vaccination is estimated to prevent about 90% of cervical and anal cancers and about 90% of the other oral pharyngeal cancers. So for every 50 to 100 adolescents who are vaccinated on time, one cancer, the modeling says you're preventing about one cancer. So for a little pediatrician, you know, who I don't see, you know, or I wasn't seeing tens of thousands of patients. I mean, that's on a public health scale. We think that way. But even on the, who am I seeing in my office? For every 50 to 100 adolescents that you vaccinate, you're probably preventing a cancer. I think that makes it all worthwhile. Okay, moving on to HPV vaccination rates in the United States. This graph shows you the vaccination coverage by year among adolescents 13 to 17 years. So this isn't, young adults. This is just 13 to 17 years of age. Then, and you see this, we started 2008. I made that big. And this is 2022. This is 80% if you go this way, 60% if you go this way. The green line is TDAP, which you would expect to be high because many school districts require TDAP for to get into high school, because we don't want pertussis in our schools. The blue is having at least one dose of men ACWY. The orange is at least one dose of HPV vaccine for males and females. So one of the things looking at this, you see the big difference. And it's, you could say, well, HPV has a problem because it's hard to get adolescents in to see a vaccinator, whether that's their own primary care doctor or, if they got it at the health department or school clinic or wherever, it's hard to get them in. But we know that when there's a will, there's a way, because there's a big difference between TDAP and meninge. And so to me, what we're seeing here is that we need to increase the will as much as we have a will to get our kids vaccinated against TDAP, tetanus, pertussis, and diphtheria, and against meningitis. Parents, of course, are terrified of meningitis, and so very willing. So there is something just inherently different about HPV that makes people feel like it's more optional, or that they're more hesitant about it. But we need to overcome that because of the cancers we just talked about. This is, so for everybody in the United States at present, you need at least 2 doses to be up to date. And so we see that there's a big drop off between at least 1 dose and being up to date for age. And the other thing I'll point out is that there was a little bit of a decrease in HPV vaccination. Here's when the pandemic started, and we dropped off a little bit, and we'll talk more about that. We are still overcoming that. This shows you the up-to-date for at least, or not up-to-date. This is at least 1 dose of HPV vaccination for age 13 to 17. This is 2022, the National Immunization Survey for teens. And you see the different rates in different states. Iowa, really high at 87.9%, Minnesota at 86.9%, North Dakota at 82.9%. So still really good. And I know that you guys are working really hard at this. Look at the difference between North Dakota and South Dakota. They're in a different level. And so we need to be having these kinds of presentations in South Dakota. And then Wyoming, really low. One of the things that worries me, of course, is that where you grow up shouldn't determine if you're protected against cancers. And so I just worry about kids who aren't getting, when only 2/3 of kids in your state are getting vaccinated, and therefore protected against some pretty nasty cancers. Oh, if you ever want to see a video about oropharyngeal cancer and how hard it is to go through treatment for oropharyngeal cancer. When you think about oropharyngeal cancer, this is an area where you breathe, you eat, you talk. And so when there's a problem in that area, you're going to have problems with breathing, eating, and talking. And so I know that Iowa, for example, had a guest speaker at one of their conferences that I had the privilege to be there, and I heard him talking about what it was like to go through radiation treatment on his oropharyngeal cancer. And it was horrendous. He couldn't eat. He lost all kinds of weight. Very painful. Okay. HPV vaccination rates by subgroup. So this is another thing that's really important. This is in 21 and 22 overall vaccination coverage for ages 13 through 17. And I just want to point out that even in 2022, and I'm looking just look at there's a lot on this slide, I'm sorry. But at least one dose is 77.8 for females, 74.4 for males. So we still need to get that message out about this vaccine isn't just for females. There shouldn't be that much of a discrepancy because, why would there be? Especially knowing that oropharyngeal cancer is more common for males than cervical cancer is for females. This is HPV vaccination coverage at age 13. So it's not 13 to 17. Now I'm just looking at age 13. So one of the reasons I find this interesting is because, again, usually at age 13, we don't have to worry about sexual exposure. So, I mean, the sooner you can get people vaccinated, the better. This is the rates by, the fancy word is rurality, how rural. So this color, which is kind of brown, or it's actually, I would call it cashmere versus gold. Cashmere is if you live in a city. This is more suburban, and this is rural. It's a normal brown color. So this is, there wasn't enough data for at least one HPV dose, but if you look at up to date, your risk of being up, or how can I say this? Your chance of being up to date was much lower, 55.1 versus 43, much lower if you lived in a rural area than if you lived in a city. Now that makes sense in this, because when you think about access to a place that has HPV vaccine, if you live in a rural area, it might take you much longer to get to a site that has the vaccine. So this isn't necessarily hesitancy, although it might be, some hesitancy involved. But being in a rural area, and so you think about North Dakota, a lot of it is rural. This is by race. And so white, Black, Hispanic, Asian. Let's look just at having at least one dose of HPV. Your chance of being up to date, or of having at least one dose, if you're Hispanic, your chance of having at least one dose is the highest. Black, almost as high. Well, 8 points difference. Am I thinking of this right? White is lower and Asian is lower. So there aren't many vaccines where you have lower rates of being up to date if you're white. But HPV, the disparity is the opposite of the way we usually think about vaccination disparities. There are lower rates of vaccination if you are above poverty. The cashmere is at or above poverty line. Gold is below poverty line. So let's look just at having at least one dose. The rate of vaccination is higher if you're below poverty level. Isn't that interesting? And of course, this is by insurance, private insurance, Medicaid insurance, other insurance, or uninsured. And as with almost all preventive services, if you're uninsured, you're most likely to not have the preventive service. So lower rates if you're uninsured. So in terms of coverage, there's good news and bad news. HPV vaccination covers have risen a lot over the last 10 years. Coverage remains far below desired and far below most other adolescent vaccines, except the second dose of meninge and flu, which is not our most popular vaccine. There's still a large gap between having had one dose and being up to date for age. The rates were rising, but then plateaued and dropped off a little during the COVID-19 outbreak. The rates are lower among people who are white than Black or Hispanic, and rates are lower if you're rural, uninsured, or above the poverty level. How am I doing for time? I'm going, so I'm going to just say this quickly. We know that well childcare was disrupted during the pandemic, and so it's not surprising that HPV vaccination rates fell off. And there may also have been more, well, I think it's been demonstrated that there's more vaccine hesitancy since COVID-19, which when the outbreak started, I thought, oh, this will make it so that vaccine hesitancy will be over because everybody will see how important vaccines are. But that's not what happened. This is a study, a group from a research team that involved UCLA, University of Rochester, Children's Hospital of Philadelphia, looked at missed opportunities for adolescent immunization at well childcare during the pandemic. And this is just to say that they were missed opportunities for vaccination. So what I mean by that is that a kid makes it into the doctor's office, but leaves unvaccinated, even though they were due for a vaccine at that visit. That's a missed opportunity. And so before this is for HPV, the red is meninge, and the gold is Tdap. There weren't many missed opportunities for Tdap, and there weren't many for meninge, but there were a lot for HPV even before the pandemic. But they seem to be dropping gradually from 2008, this is January 2018 to January 2020. But then here's when the pandemic started, and you see that then it started going up, and the rate of rise for HPV missed opportunities was much higher than the rate of rise for the other vaccines. Okay. I'm going to just skip this. I think you, well, I think you get the point. Okay, and we talked about dental professionals can help, and mostly by making referrals back to primary care or the pharmacy, wherever kids in your area get their vaccines. The next thing I'm going to talk about is starting at age 9 or 10. This is a hot new topic. ACIP will probably take this on, I believe, as early as June. And so in the United States, we may go to, right now there's, well, okay, let me just say, right now there's a discrepancy. ACIP says that routine vaccination of preteens at age 11 or 12, but the vaccine series can be started at age 9. The AAP says something just slightly different. All adolescents starting between 9 and 12 at an age that the provider deems optimal for acceptance and completion of the vaccination series. ACIP has kind of hung on to this 11 or 12 because they felt like the adolescent platform was important. AAP just felt, let's get it done, that we could break up so that kids aren't getting 3 vaccines at a 3, or if you include COVID and flu, 5 vaccines at a single visit. I mean, most teenagers don't want more than 2 injections in an arm. American Cancer Society uses this graphic. On time is 11 to 12, late is 13 to 14, and late with an extra dose because you go into a 3-dose series if it's 15 to 26. So American Cancer Society really comes down on the side of 9 to 12. The reasons to vaccinate as early as age 9, well, because it gives you more opportunities to vaccinate, and our vaccination rates are suboptimal. So the more opportunities to get them while they're in the office, the better. It spreads out the shots again, so you don't have to have 2, 3, 4, 5 vaccine, or yeah, you could even have just 1 HPV at 9 and then do your others later. And there's no known downside. It looks like the immune response is very robust at age 9. Antibody levels appear to plateau for a really long time. So the modeling suggests lifelong protection. So there's no downside to doing it at age 9. I think a lot of offices are switching over to this now. And then I also think that a lot of people don't want to get into the whole thing of sexuality. And so by saying, here's a cancer preventing vaccine, you don't have to get into how the HPV is spread. And when you think about it, when we talk, when we say you're due today for your polio vaccine, we don't talk about how polio is spread, that there's fecal oral spread all around us. We don't explain, that the surface that you touched was touched by somebody who had poo-poo on their hands. And so I don't think we need to explain how HPV is spread. The point is that it's a cancer preventing, and whether almost all people will have sex, even if you have sex for the first time when you're married, that doesn't protect you from HPV infection if your partner had a previous partner. So sort of in the United States, I think there's a strong feeling of boys will be boys. And so a boy who enters marriage not a virgin isn't as shocking, but there's a lot of sentiment that a girl should enter marriage as a virgin, but she's not protected if her partner isn't. So protect her yourself by getting her vaccinated. This just to say that this is 2013 data on sexual debut. Before age 11, there is almost no one who has had sexual contact. Does vaccinating at age 9 by itself? These are the questions that are going to come up for ACIP. Does it increase timely vaccination? There's a randomized controlled trial that's looking at that. We won't have data on that until April 2026. Does it change the provider-patient relationship, whether it makes it easier for you because you don't have to talk about sexuality, or are there any negative impacts? And then the immune response, we want to make sure that the duration of protection is really lifelong. And so ACIP will be looking at data on that as well. So I'm going to keep going because I think you get the point of that. And this is the NIH-funded randomized controlled trial that will be, data will be available. Will the United States change to a 1-dose schedule? This is another big one. ACIP is reviewing literature now to answer, is a 1-dose vaccine schedule for HPV effective enough to protect people, the kind of protection that we're seeing now? And would a 1-dose schedule be long lasting? So these questions are difficult to answer because there's no easy way to, you can't just look at the antibody levels and have an answer for either of these. Globally, there's been a lot of interest in this question because the vaccine isn't free and it isn't easy to get people back 2 times or 3 times if there are 15 or more on a regular schedule. And so globally, there's been a lot of interest in this question too. CDC has examined many trials in which subjects completed only 1 dose in Costa Rica, India, other places. And so the data that they'll be looking at to answer these questions are from other countries. Right now, this is just the Costa Rica vaccine trial. It looks like the vaccine effectiveness at 1 dose is 1 dose, 2 dose, 3 doses is all against cervical infections is all quite high. So that's exciting. Wouldn't it be great if we could protect people with just the first dose? This is duration of immunity. You see here the purple's after 3 doses, the red is after 2 doses, and the blue is after 1 dose. And you see that the antibody levels, the geometric mean titers, keep going. This is 11 years out. And so they seem to plateau at a high level. And so again, very hopeful that even 1 dose gives you long-lasting effective immunity. So I'm just going to say that the World Health Organization has now gone to they say that on the basis of the recent data on efficacy and effectiveness, they are endorsing an optimal the optimized schedule for 9 to 14-year-olds can use a single dose or a 2-dose vaccination schedule with at least 6 months between. And that countries and territories of the Americas should use this is PAHO says, should use a single dose schedule. So globally, the World Health Organization is going to a 2-dose, 1 or 2-dose schedule. PAHO is going to a 1-dose schedule. So stay tuned to see what happens in the United States. Will we be going to a 1-dose schedule? So then, I'm way over, sorry. There is no CME for this talk, but I work with Immunize Kansas Coalition. And if you go to the IKC website and go on to the education modules, click on there, you will find an education module on HPV that I helped design. And so it's a lot of the same information that we just talked about. And there is CME available through IKC. They also have some wonderful other things that while you're there, the modules are so good because they're really interactive. They're to the point. So busy providers who just want to get to the point can get there in a hurry, and they're visually engaging. I think we got great feedback about it's some of the most fun and informative at the same time. While you're on the Immunize Kansas Coalition website, I just want to say, take a look at vaccine fears overturned by facts. They've done a beautiful job. They invited people who used to be anti-vaccine parents who converted to being pro-vaccine parents and helped them design fact sheets on different vaccines. I think they're fabulous because they really hit the points that the parents are worried about. There are a lot of single question handouts like this one. Does the HPV vaccine cause infertility? There's also handouts on aluminum, autoimmunity, social media spread of misinformation. So a lot of single topic handouts that I think are great. They're in English and Spanish. The graphics, as you see here, they're really attractive, colorful, upbeat. I also want to mention the Autism Society. I have a 31-year-old severely autistic, nonverbal male son. And every time I've been approached by any group related to autism, it's been anti-vaccine. And so I was really positively, blown away by the vaccine education initiative by the Autism Society of America. I put the website here so that you can find this easily, because if you veer off, that there are other autism groups that are anti-vaccine. The Vaccine Education Initiative, they've done beautiful work to make it so that that families of autistic kids are getting the same information, the same good, accurate scientific information, and they're doing it in an upbeat, very inclusive way. I think that they're great. I can't say enough about immunize.org. If you haven't ever been on our website, it's new, it's easy to navigate, and it's amazing the amount of information and the detail. Every handout is reviewed every month to make sure that it's up to date. There's a section, you see it right here, it's called Ask the Experts. If you want to be the smartest person in the room in answering vaccine questions, look at Ask the Experts, because it has the easy questions and the hard questions. And Dr. Moore, Kelly Moore, is amazing at going through these scrupulously to make sure that they're up to date. This is just our HPV information is wonderful. And this, again, this Ask the Experts site. If you don't already get our newsletter, IZ Express, it is absolutely free. We won't bug you for, to upgrade or anything like that. It's absolutely free. It's weekly. If you have time, you can look, and you can look at the table of contents and see what's interesting and pop right over to it. Again, it's a labor of love, and it's beautifully done. On our website, it's under news and updates, and you can just subscribe now, and you just give us your email and we'll send it to you free every week. And if you subscribe and the people who work for you don't, let them know about it. I want to make sure that you heard this. The NDSU had a virtual webinar, Effective HPV Vaccine Communication, which I did not talk about today. Because Noel Brewer and Jessica Young are just the absolute leads in this. And so if you want to know more about effective communication and the science behind that effective communication, go to the NDSU website and see the webinar back from July 17th. I had to put in, because I'm not an OBGYN, and so I have never done cervical cancer screening recommendations. If you need to know and they are changing. So if you need to know what the newest cervical cancer screening recommendations are, go to this website, the Preventive Services Task Force, to learn about that. So HPV infection is a major public health threat. HPV vaccination rates are suboptimal, with certain inequities, such as kids that are rural, for example, are less likely to be vaccinated. COVID-19 pandemic has affected HPV vaccination a bit, and we need to recover from that. ACIP is considering a change to a one-dose schedule. HPV vaccination initiation at 9 or 10 is already routine from both ACIP and ACIP and AAP standpoints. And I think that it's, for many offices, it's an easier way to get the job done. There are great materials available to educate providers and parents out there. I hope you'll use my slides to look at some of the ones that you're not already familiar with. And that's I think I've left myself 2 minutes for questions. Sorry.
Hey, that's okay. I'm going to quick share my screen so I can get our survey up on that, if you're okay.
Yeah, okay. Do I have to do anything to get
Just unshare quick.
there?
Yeah, that's okay. All right. Okay, thank you so much, Dr. Humiston. That was such great information. We had a comment come in about those rates of insured versus uninsured were interesting. This fall, I had found it interesting at our back to school clinic that most all Medicaid and uninsured kids took the HPV vaccines, where almost all the private kids had refused it. So,
So
um,
so that goes along exactly with what we saw across the US.
so that is interesting. Um,
I
really,
also say how important it is that vaccines are covered by Medicaid.
yeah. Definitely. I really thank you for sharing Immunize Kansas, the ability for people to go hop on and get some continuing education, because I know how important that is.
And
Um,
we just, just in the last, like right before Christmas, went through all the slides. CDC changed its website so
mhm.
that a lot of the links were broken because CDC changed their website. We just went through and cleaned everything up. So that module is great. And
Awesome.
for people who, like, let's say you're the nurse manager for an office and you want everybody in the office to be up to date on this,
Mhm.
great way for them to get up to date without you having to do an in-service yourself.
Absolutely. And we'll link all these resources in the follow-up email and with the recording. Also, we have partnered with the Autism Society of America for 2 years on mini grants. So that was, thank you for mentioning them, because they do have amazing resources and support to offer. Love them.
Yes. And it was such, I mean, we know from statistics that a family with one child who has autism, that subsequent children are less likely to be vaccinated. So the fact that they're doing it is super important.
Mhm. Yes. Well, I don't see any other questions that came in other than Chelsea Olender. She put an NDSU webinar regarding HPV that's coming up on the 20th
Oh,
of
good.
January, a link to that. So
Great.
that's wonderful. And yeah, so
I
just
mean, I think this is why North Dakota is doing relatively well, that, compared to your neighbors, you're doing relatively well because there is so much emphasis. So good on you.
thank you. I think it's a statewide effort, right? So I know we're at time. Thank you again, Dr. Humiston,
My
for
pleasure.
just wonderful presentation, and to everyone who could be here today. You can stay connected with us by following us at Healthy Nodak on Facebook, Instagram, and Twitter, and Foundation for Healthy North Dakota on LinkedIn. And also you can visit the link to join our coalition and scan the QR code and take our evaluation survey. It will also be emailed out though. So, all right. Have a great rest of your day, everyone. Thank you.
You.